What is elderly? So patients with myeloma usually are diagnosed, the median age of diagnosis is 72 years in Europe. And as you see here, the incidence is higher in Black people. These are Caucasians, and the incidence is somewhat lower in Asian people. Now, elderly people and elderly myeloma patients present with more unfavorable risk factors when you look at these data and compare the patients of age 80 or older with very young patients. You see more patients, elderly patients with increased beta-2m, low albumin, and this results in higher stages at presentation as compared to the younger patients. And of course, elderly patients present more often with anemia and with other risk factors. But when you look at the bone marrow plasma cell infiltration and compare that in different age cohorts, there is no difference. So the plasma cell infiltration is rather stable in different age cohorts at diagnosis. Now, age is, of course, the biggest risk factor for reduced outcome, for reduced and shortened survival, and this is a survival which has been corrected for the different life expectancy, because what you usually see is survival, observed survival. This is survival which is already corrected for the different life expectancy in different age cohorts, and what you see here, when you correct that, in spite of correction, you see that the elderly patients do very poorly as compared to the younger patients. What you see here also, and I think this is some food for the discussion later on in the second half of this session, is the long-term survival in young patients with conventional therapy plus or minus transplantation. Now, what are risk factors in elderly patients? Aside from higher age, for higher mortality, of course, decreased renal function, grade 3 or 4 non-hematological adverse events, cardiac adverse events, infections, of course, and drug discontinuation due to adverse events. So all these factors associate with increased mortality in patients. So the higher risk of mortality in elderly patients has nicely been worked out by our Italian colleagues, and they looked at patients of age 75 or younger and elderly patients, and you see when you look at the survival of the younger patients, of course, survival 3-year survival rate is higher in the younger patients as compared to the older patients. That's what you expect. But when you look on the impact of different treatment regimen in terms of mortality, you see melphalan prednisone is associated with lower mortality risk compared to more intense regimen like VMP and particularly VMTP, VT maintenance here, and these are the patients, the elderly patients, and they have the higher mortality rate when they are treated with more intensive regimen. Age, of course, should not be defined on the basis of chronological age, because when you look at these three persons, these three individuals, they are all of age 70, and you see here this is a very fit lady, this is an unfit lady, and unfortunately this is a frail patient, and you see here this enormous difference, and the difference increases with increasing age. But when you look at the biology of the myeloma cell, all what we know as of today, there seems to be no big difference in the biology of myeloma in different age groups, which is in contrast to what we know from AML, where we have more patients, elderly patients with more aggressive karyotypes. So in myeloma, there doesn't seem to be a migration of aggressiveness with increasing age. So what shall we do in our patients? We should, and that is data from Antonio Palombo. So you assess frailty, and then you distinguish between your patients, whether they fall in the fit category or into the frail category or unfit category, and depending on the class they are in, you select treatment. Here you go with full dose. You may use a 2 or 3 drug regimen, and in the frail patients you have to be very careful. You may want to use 1 or 2 drug combos, and of course you will go with very reduced doses when you start treatment in your frail patients. How do you assess fitness? Again, from Antonio. You use 4 different parameters: age, activity of daily living, instrumental activity of daily living, and the Charlson comorbidity score. And with these 4 parameters, you classify your patients again into the fit, unfit, and frail patients. And then, according to the class they are in, you decide about the appropriate treatment in your patients. And Antonio also presented some recommendations for dose reductions. And these are, of course, expert-based recommendations. They are not based on scientific data, but I think they are very helpful for clinical practice. So if you have a very frail patient, you want to go with dose level -2. And if you have a fit patient, you will go with full dosing in your patients. In addition to this assessment, you have to, of course, acknowledge that patients who are diagnosed with polyneuropathy before start of therapy should be spared the toxic effects of bortezomib or thalidomide. So if you have an alternative, of course, you want to go with the alternative and not with bortezomib and thalidomide. If the patients present with renal impairment, of course, you need to adapt lenalidomide dose if you want to go with lenalidomide. But in those patients, if they present with acute renal impairment, you should go with a very active combination, possibly a combination containing bortezomib and high-dose dex. But you have to be careful again in elderly patients when you administer high-dose dex because of its toxicity. In patients with bone marrow insufficiency, you would like to probably, if the patient is a low-risk patient, you may wish to go with dexamethasone alone until improvement of his myeloma. If the patient comes in with cardiac arrhythmias, you have to be very careful when you want to use thalidomide or high-dose dex, because both drugs can be cardiotoxic, and their cardiotoxic potential is higher in elderly patients. Frequent infections, of course, you will be very careful regarding the dosing of your drugs. You would like to consider antibiotic prophylaxis, if there's cognitive or functional impairment, you may consider intravenous regimen in order to improve or to assure excellent compliance of your patients. So what are the combos which are available? Very rarely you will go with 1 drug combo, I think, but you will go with 2 drug combos in many of your patients, or 3 drug combos. Of course, Antonio has shown that VMPT followed by VT improves survival, but this is a very aggressive regimen which is probably most suited for young elderly patients. And I should add, there are now 3 studies which we should take into consideration. This is the Nisvetsky data, which have been updated at ASH, where he compared VD with VTT and VMP. So 3 bortezomib-containing regimen, 2 drug regimen, 3 drug regimen, and VMP 3 drug regimen. You obtain slightly higher response rates with VMP, but when it comes to progression-free survival and overall survival, there is no difference. And the same is true for these regimens, and the same is true for these regimens. So there's no difference in progression-free survival and overall survival when you compare these drugs in elderly patients. And these are particularly patients of age 75 or older, and I show you data from this study. So cytogenetics still play an important role in elderly patients as well, of course. You see here patients with translocation 414 and those with deletion 17p too poorly as compared to those with standard risk cytogenetics. And this is also true in the very old patients, in patients aged 75 or older. So cytogenetics, of course, are important risk factors also in the very elderly patient group. But, and this has been mentioned before, you can build a risk score on 3 parameters. You use age, comorbidities, and cognitive or physical conditions. And if the patient is young, has none of these comorbidities or conditions, he will be classified as fit and comes out with a score 0. If he has 2 or more of these parameters, he will be classified as frail with a score of 2. And when you apply this score to your patients, what you see is following. Patients with score 2 or more, the frail patients have significantly reduced survival rates as compared to those with unfit, who qualify for unfit, and those who are qualified as fit patients. So there's a significant difference. And when you look at overall survival at 18 months, you see fit patients do much better as compared to the frail patients. And when you look at the 6 months risk for severe adverse events and treatment discontinuations, of course, the risk is much higher in your frail population. And that has been mentioned before again, that the fitness score has higher prognostic impact than the cytogenetics in the elderly patients. Is a response of importance in elderly patients? In my opinion, it is, and this has been shown in several studies. So if you look at the patients with complete remission as compared to those with very good partial response or partial response, what you see is a uniform picture. Those with complete remission do much better in terms of progression-free survival, and of course also in in overall survival. There may be some exceptions to this rule, I acknowledge that, but in general, responses of importance and complete response, of course, associates with better outcome. This is also true in the very elderly patients aged 75 or older. Now, I'll just show you this trial which compared these 3 regimens. Again, this is a trial which has been conducted in patients of age 75 or older. And the question is whether Velcade plus prednisone results in a similar outcome as compared to VCP, Velcade, cyclophosphamide, prednisone, or VMP. And when you look at overall response rates, VMP seems to induce higher response rates, but importantly, progression-free survival and overall survival is not different. And of course, there's a higher discontinuation rate in the elderly patients with a more aggressive regimen with VMP. This, when you then apply the fitness score to your patients, you see what you expect. The fit patients do much better in terms of overall response and overall survival, and the rate of severe adverse events and discontinuations is of course highest in your frail elderly population. This trial has been alluded to already. It's a beautiful trial because it's the biggest trial which ever has been conducted in elderly patients with multiple myeloma. More than 1,600 patients have been enrolled, and you see here the randomization in continuous Revlimid dex therapy. So continuous until progression or intolerance as compared to 72 weeks of Revlimid dex and compared to 72 weeks of MPT. This equates to 16 months, roughly 60 months of treatment with MPT or with RD as compared to continuous treatment. You see when you ask a question, how many patients are still on study when the data were analyzed, 23% as compared to null here. And so patients treated for more than 2 years, 39%, 4 out of 10 versus none, of course. And importantly, this treatment was well tolerated because when you look at study discontinuations, there is no difference in the rate of discontinuations. And so if you tolerate this treatment, you tolerate it for long, as shown here. Now, a significant proportion was older than 75 years, and the response rates are shown here. Response rates were higher with Revtex as compared to MPT. Complete responses were higher with Revtex as compared to MPT, and duration of response was much longer with continuous RD therapy in this group of patients. And you see here the progression-free survival. The progression-free survival rate at 3 years was 42%, almost double as a rate in patients on continuous Revtex as compared with those on 18 cycles of Revtex and 12 cycles of MPT, 23 and 23%. And when you ask whether this translates into better survival, the answer is yes. Before I show it, this is, of course, risk factor analysis of in terms of progression-free survival, LD compared to MPT. What I want to point out here is that the elderly patients do quite nicely here, but the younger tend to do a little bit better. But here you see the risk profile, and with the exception of those patients with high-risk cytogenetics, all patients seem to benefit from RD therapy. Overall survival is shown here, significant improvement for continuous RD therapy as compared to 18 cycles RD and 12 cycles MPT. With that, I would like to come to the treatment algorithm. We have already alluded to that we should assess the fitness in our patients, and we categorize our patients into these 3 groups. And when it comes to treatment, then you have several choices. You can use bortezomib-based regimen, bortezomib-imid combinations, imid-based combinations, or bendamustine or other combinations. And we should be aware of that there's no big difference between these regimen in elderly patients, and so you can use them probably as well as these regimens which have been tested in randomized trials. And of course, maintenance can be considered in some patients, elderly patients, but the data are rather scarce here. With that saying, I'd like to come to my conclusion. So when you consider treatment and care of elderly patients, you have to be aware that elderly patients constitute the majority of our myeloma patient population. They show a great variability in fitness in a given age group. They have more unfavorable risk factors. They are more vulnerable to toxicities of therapy. They have more drug discontinuations, and they have shorter survival. And treatment should be selected by considering all of these conditions and should be provided with special care.